Well, welcome to this month's Integrated Care Roundtable. We're so excited to be here. We're going to talk about asthma today. So hopefully that's something that we're all encountering in our practices and really wanting to learn more about. I think it's going to be very informative. We're excited to offer a 1 credit CE today for today's discussion. It's free for MOPA members. If you are not a MOPA member, you can email after this roundtable support@mopaonline.org, and they will process a payment for that. In order to make the CE process more streamlined, please take a moment to enter your full name into the chat box so that we can note your attendance. And then at the conclusion of the event, we'll email you a brief evaluation on today's discussion. Fill that out, and then we'll email you the CE credit by early next week. If you have any questions, again, you can always email Emily at support@mopaonline.org for any additional questions. This is a discussion. It's not a seminar. It's interactive. So you are free to interrupt us, ask questions throughout, but we're also going to save some time at the end purposefully for a discussion. So if you want to wait for that, you're welcome to. If you don't, you're welcome to jump in at any point. You can turn on and off your video and audio at any point that you'd like. If there's background noise, Emily may mute you just so that our discussion can continue, and you can unmute yourself at any point that you want to ask a question or have a comment. You can also submit your thoughts via the question and answer chat if you prefer that. Finally, it's a reminder that this session is being recorded for possible future use by MOPA, and the views and opinions expressed during this presentation are our own and do not necessarily represent the views of any of the Missouri Psychological Association. So now it is my pleasure to kick off this event this morning by introducing a fellow panelist and myself. I am Chelsea Gillum. I'm a clinical psychologist. I am the System Director of Adult Integration at Burrell Behavioral Health. I'll pass it off to Kristen, Robin, and then Michaela.
I am Kristen Thompson. I am the System Director for Pediatric Integration at Burrell Behavioral Health. And Robin's up. Did I say all the things? I got distracted because I couldn't find my mute button.
I'm sorry for any background noise on my end. Hopefully it will be gone quite soon. My name is Robin Lute. I'm a licensed clinical psychologist. I'm joining the Compass Health team as a psychologist here quite shortly, and am very much looking forward to that.
And I am Michaela Muehlbach. I am the Deputy Chief Clinical Officer of Outpatient and Psychological Services at Compass Health Network. I wanted to add today that we always strive to bring ethics and diversity into this space to have a full, robust discussion as it pertains to any of the topics that we have. And we want to invite people to be curious observers with us and understand that this is a learning environment. We come at this with a space of wanting to learn. And so please understand that we may not know every term or word, but we are way open to hearing and learning from each of you if you want to correct us and help us along that space. So we're so excited for you all to join us today and look forward to the ongoing discussion.
All right, so we're going to start with determinants of health, disparities, and diversity. Let me get my screen settled here. I've got a lot going on. Oh, there we go. I put a lot of information in some slides, and then I found this graphic. So I just erased everything and put this graphic on here. I want to really kind of drive home. I want you to take a minute to digest this. I thought it was important. Black Americans are nearly 1.5 times more likely to have asthma. Puerto Rican Americans are 2 times more likely to have asthma. Black Americans are 5 times more likely to visit the emergency department due to asthma. Black Americans are 3 times more likely to die of asthma. Black women have the highest death rate due to asthma when we factor in sex. These are huge statistics that need to be considered. When we look at determinants of asthma morbidity, diversity, this could be a 3-hour CE on its own. There is so much information. So this is just the tip of the iceberg. I'm going to cover lots of information about this really quickly. And I want you to take this information, and then also I'll put lots of links where you can really get the full picture from where I took this information from. Because again, I cannot possibly cover everything that needs to be covered. There are a lot of reasons that this exists. There's a lot of really sad reasons that this exists. The one that we're going to focus on primarily, initially, it's going to be medication adherence, because there's a lot of factors that go into why medication adherence is an issue and why it contributes to disparities. But just to get a full scope of all the things that are kind of interplaying one another in regards to diversity and disparity. We have structural determinants such as systemic racism. We have segregation, discriminatory practices that play a part. We have social determinants such as socioeconomic status, education, neighborhood, physical environment, employment, social support networks, and access to healthcare. We have biological determinants such as genes and ancestry. We have behavioral determinants such as tobacco use and adherence to medications. While I hope that we address all these things in the actual exam room, a lot of what behavioral health consultants do is focus on medication adherence. So one of the core features of the disease for patients is using medications. And as we know, particularly anytime we add a layer, it creates a barrier, a layer of requirement for a person to meet that expectation. It creates a barrier. We know that in integration because we're embedded for that reason, to reduce those layers and barriers that exist. And as you can see, maintaining medications when you have asthma requires a lot of layers. And anytime we have that, we're going to lose people. And you can see the graphic on there where we lose people consistently as this occurs. There are limitations with just getting an initial diagnosis and getting a prescription that's appropriate for an individual, being able to fill those medications, being able to continue with those medications and continue with those appointments. What we see is adherence, and only that small piece of adherence. There are lower rates among minorities, some of that based on SES, and some of that based on just the disadvantages that exist because of their minority status. The socioeconomic status disadvantages commonly associated with minority status. And some of the facilitators and barriers, so we can break these down and really organize them by individual factors, patient-physician interaction, and our healthcare system. When we look at individual factors, there's a lot that goes into this. A lot of this is medication beliefs. We see greater negative beliefs and more concerns about asthma medication found among minority groups, including African American and Latinos in particular. Depression, I don't think this is any surprise to anyone. Adherence to much of any regimen when someone's experiencing depression is going to be difficult. That's no different than it is in asthma. And then we see the use of complementary and alternative medications. We see a higher rate of CAM use in individuals from certain racial and ethnic groups, including African American and Latinos as well. That's not necessarily, they're not using it necessarily as a replacement for treatment, but it actually may be used to supplement traditional care for those with more severe disease, and then also as an alternative when medications are not easily obtained for a variety of reasons. Patient-physician interaction, we have individuals with limited English proficiency. Usually that's a lot, it's correlated to socioeconomic disadvantages, low levels of acculturation, and that will really create a barrier in patient-physician interactions. And we've seen that patient care has been lessened when an individual is attending an appointment with a limited English proficiency. And then also unintentional implicit biases play a role in disparities in healthcare, affecting communication patterns with patients and even the management of their medications. Healthcare system alone, insurance coverage, this is huge. There's actually a study that says that publicly insured children with asthma are more likely to be discharged with suboptimal medication regimens than those with private insurance. That's, again, just the tip of the iceberg, but insurance plays a big role in this. Also individuals, families who live from disadvantaged areas, they have exposure to violence and crime effects. And that affects their ability to have consistent medications, even after we adjust for socioeconomic factors. So that really suggests that features of the social environment have links to asthma management behaviors, such as medication adherence. I'm not going to read these to you, you can read, but I do want to take a minute. This is the big summary on health disparities and kind of what was taken out of an article that I want to post later. I think it's important for us to just take a moment to digest this. I'm going to pass this on to Kristen.
Thanks, Chelsea. You know, and I think Chelsea's given us a great intro to all of this. And I'm going to talk about pediatrics. Michaela's going to talk about adults, but really everything she just went over is the backbone for a lot of the problems in the treatments we see in both populations, which is of course why we wanted that topic to come first. But I'll just give you a little bit of some snapshots of some research about asthma, specifically with pediatrics. One, this top one is a review that is really helpful to just overview in general all of the mechanisms for the psychosocial factors impact on asthma outcomes. We naturally think about how psychosocial factors are going to impact things like health behaviors, how you think about your illness, your ability to have good adherence and avoid triggers, et cetera. Those feel very naturally behavioral. But it's also important to note that with asthma, there's also direct impacts of psychosocial factors on your endocrine system, your ability to fight disease, your central nervous system, cortisol and stress hormones. I mean, those things directly impact your body's physical health, which includes asthma control. So it's really nuanced here, and there's a lot to it in terms of how controlling not just behavior, which the behavioral health consultants are great at, but also modifying psychosocial factors to the degree that we're able can really impact asthma outcomes. One of these that comes up again and again when we're talking specifically about children is parental depression. That one is sort of well known and understood, but this Weinstein article I think is really an important addition to that because it talks about family chaos. So it's not just depression, but it's that instability in families that really makes good asthma adherence and treatment really difficult. And that's absolutely a space where behavioral health can intervene and help families work towards routines, predictability, planning, et cetera. We go ahead to the next one, Chelsea. This one's really interesting to me. So asthma outcomes have not improved at the same rate as advances in drug treatment. Why? Well, it's behavior. So we're getting better medications, we're getting better treatments, but we're not addressing the behavioral components of this. So this is an article that was written by a physician, and it was interesting because he sort of called out physicians in a lot of it. And one is there's an underuse of evidence-based guidelines, and that is more associated with the medications. And that really hits on a lot of the points Chelsea talked about insurance barriers and access to quality treatment. But the second two are things that behavioral medicine really can say something about. And the first one is communication between physician and patient. So there isn't always good communication about exactly what is this asthma plan? What are the environmental changes I can make? Why are those important? And is the physician communicating their importance in a way that resonates with the family? Are they really hitting on the things that they value in a way to connect in a meaningful way? And then low adherence rates is huge in terms of how we intervene. And then lastly, there's a couple reviews that just talk about the degree to which behavioral interventions work. And there have been many studies where you have a psychologist or a community health worker, or a BHC intervening on asthma and seeing great outcomes. The first one is an example where they used electronic monitoring to monitor medication use, but then it was the psychologists in this study that really came in and addressed those barriers to adherence and problem solved and worked with families on motivation. And they saw an increase in the group that included the behavioral health provider. So it wasn't just the monitoring, it was the person using that data to shape behavior. And then, the second one is a good, again, overview of lots of different ways in which treatment's effective, but self-management training. So teaching people how to manage their own asthma, breathing training, exercise and physical activation have shown positive outcomes. So if you go on, Chelsea, I want to just talk about with asthma treatment, there's really three components. There's medication. That's what we all think about, and that is critically important. But then there's also adherence to that medication and this third variable of environmental modification. I can tell you, so my son is 4. He began having serious asthma issues at 6 months old. He's had 4 PICU hospitalizations. We have been on this asthma journey. And as a privileged middle-class white woman, I can tell you we have struggled tremendously with a lot of these things we've talked about. And I know I have access, right? I don't have a lot of these barriers. And I'm grateful for that, but also recognize that if I have struggled with all of these things in my favor, this is just a really hard thing. And I can tell you, nobody has had a conversation with me or my family about environmental modification. We have seen allergy and asthma specialists. These are things I've learned on my own. And so making sure that all of these pieces are part of it, not only, can we as behavioral medicine talk to our patients about whether or not they're aware of these things, but are they doing them? So, I even just learning about them, I'm like, well, there's these things I can do, but how much of a difference does it really make? Because it's going to be really hard. And am I motivated to make those big changes in my environment if it doesn't really matter? So, what's the motivation around that? And then adherence, again, adherence is hard because a big part of adherence is truly understanding what you're adhering to. What is the regimen? And again, I can say, I struggled with this. So I have this asthma plan, but what does it really mean? And the one, it's just embarrassing to even say, but wheezing, is he wheezing? I don't know. What does wheezing sound like? Is the parent, especially with kids, instructed on what are these terms? What do they mean? What are you looking for? How do you know when asthma is exacerbating? Are we really taking the time to educate and make sure families understand and have the tools to manage their child's asthma at home? So there's this, do they understand the instructions, but also who's responsible for monitoring medication use? Particularly when we start talking about older children, is the expectation that the child takes care of that themselves? And are they developmentally at a level where that's appropriate? That is one thing that, in intervening in primary care on asthma issues, I heard a lot. Well, she manages it by herself. She takes her inhaler. Well, is she? And then, the cousin to that is, well, she says she doesn't need it. Her breathing's fine. And one thing we know about asthma, and one of the keys to successful treatment is actually daily management with an inhaled corticosteroid to prevent you from feeling like you need it. So there's a lot of prevention there. You may feel fine and you may continue to feel fine after you've dropped that off, but then you'll have exacerbations and asthma attacks. So it's important to help families and kids understand that it's really about prevention, and you may not feel like you need your medicine, and that's how we know it's working. But there's a lot of misconceptions about that. Is everyone educated or just the person at the appointment? So think about blended families. You may have bio mom that comes to the appointment, but then the child spends time with dad, stepmom, stepdad, grandma, aunt, etc. And the school as well. Are we making sure the schools are on board? So in behavioral health, we can really dig into these questions and make sure that there's comprehensive plan about treatment for families. We've talked about buy-in and understanding the need for treatment and what it does. Then there's this element of is the client or the family's perception of airway obstruction accurate? And so to put that simply, do they overinterpret their level of not being able to breathe? Is there an anxiety component to this or a panic component to this? Because that could contribute to overuse of medical care and of steroid treatment, which we don't want. Or are they underperceiving their own impairment, which, like I said, leads to maybe not taking the daily medication, which can be a slippery slope. So helping individuals understand how they're perceiving and what their cognitions are around their asthma can be really important to start to understand how accurate maybe they are in understanding their level of need for treatment. So that's adherence. I'm going to say, Chelsea, same thing about that's the tip of the iceberg. It's a really quick overview, but there's a lot to unpack there and a lot of space where we can intervene. And then environmental modifications. I think here the important note is we really have to be sensitive to the fact that when it comes to environmental modifications, there's going to be factors that families cannot control or they have very limited control over. So this might be like access to clean housing, neighborhood pollutants, even sometimes access or exposure to like secondhand smoke. Well, maybe grandparents are the care providers during the day while parents work and grandparents smoke, and that's just not negotiable. So we don't ever want to get in a place where we're shaming or really laying on thick about these modifications that maybe aren't accessible, but can we lean into things that they can do? So for example, like dust covers on pillows or regularly vacuuming the carpet in the child's room, things that may be more accessible. And importantly, there's what they can actually change, but there's also motivation around that. So helping families understand that these little things can make a big difference. And honestly, that they can make a big difference, but also getting buy-in around environmental changes really helps empower families to feel like they can have an impact on their child's health and there's something they can do meaningfully that's within their control. It really helps families take ownership of treatment because the environmental stuff is entirely within the domain of the family. And so getting some buy-in there really helps get buy-in to the treatment in general because it can empower families. So in terms of intervention, when you're intervening with a family, it's probably no surprise that a huge part of this is motivational interviewing, but also just problem solving treatment. So identify a barrier. How can you work around that? It's all very short term. It's stuff that we can do in the course of other treatment. So BHCs may be intervening on this directly, but even if you're in a traditional outpatient setting and you're treating a child for trauma, but you know they have poorly controlled asthma, can you spend a session digging in on some of those things and helping them come up with some solutions to intervene on these points and getting a better sense of how the family is really connecting with the disease? That's what I have on pediatric asthma.
Right. Well, the first couple of slides that I have are somewhat reiterations of what we've heard. The first one is just kind of a different way to consume that information. We've already covered this, I think, to an appropriate degree. The next one really kind of outlines what I was actually a little surprised by this. Approximately 62% of adults with asthma had uncontrolled asthma. And those range from 52%, of course, in Massachusetts to shout out 73% in Missouri. So I was like, I don't think that's really where we want to be, like, winning, because we know that that's not, that is losing in this particular space. So as we kind of go forward, we're going to talk a little bit about, well, okay, so kind of to dovetail off Kristen, like, what is in our control? What can we do knowing that that's kind of what we're up against? And so the two things I really want to outline today are really focused on what our BHCs and even our outpatient clinicians can do outside of the primary care space. And that is the asthma plan and the kind of exhale. Exhale is found through the CDC, so very accessible and easy to find. And we also know that that can be instrumental in assisting with the medical intervention. So as we kind of move forward, talking a little bit about, sorry, Chelsea, I'm clicking. I don't think you, I don't know. We set up this like click thing, but it is what it is. So maintaining good day-to-day asthma control. So Kristen spoke a lot about this as well. And with respect to like what a BHC can help with, an asthma action plan, and I'm going to provide an example of that in the next slide, but it's really important if you have moderate to severe asthma or if you've had a serious asthma attack in the past. We also want to make sure that our patients understand that like, having asthma should not be a limitation. It is absolutely a possible barrier, something to overcome, but we don't want it to be so that it interrupts their sleep or that worry or that panic that we've heard about, that what happens if and when I have another asthma attack. And so following the written plan and being preventive instead of reactive can be so much help to our patients. And so with the asthma action plan, just kind of outlining these specifically from top to bottom on the next slide, we will see that there is very specific intervention strategies that we can provide. And they're probably dealing with a little lag too, Miss Chelsea, so sorry about that. So I have it pulled up over here. Perfect. So just tracking asthma symptoms, recording those peak flow readings, assessing their asthma control. So I loved this one. This is something that I honestly use, the traffic light analogy in almost every behavioral intervention I've ever used known to mankind. And so this, I think, is a very easy way that anybody can understand, even children, right? And so that can be a really easy thing and something that maybe pops into your mind. And it's a word that can be used also within mixed company that maybe will reduce like embarrassment or maybe allow somebody to communicate when they're under a lot of stress. And, you know, remembering just a color may be helpful for them. Their medications, of course, as well as how do we recognize when we're having an asthma attack. Again, like I think there's a lot of mindfulness practices that can be valuable here in sitting in oneself, recognizing our bodily reactions and what is going on in our minds. And that can definitely help us tracking what was going on, like the antecedents and then the consequences. So what was going on before you had that asthma attack? How was your body feeling? What thoughts were going through your mind? Did a big thing happen? Did something stress you out? And when we can help our patients in any capacity form those kinds of formal plans, but most importantly, track their previous behaviors and track their symptoms and how those present, that really helps us develop a good picture of what we can kind of expect with some level of accuracy. And so a really important one on this, though, is to know when emergency care is necessary. We know that asthma can be deadly, and we want to make sure that we're providing people with the knowledge of when to go to the emergency room or call an ambulance and when to kind of manage those on your kind of lower level interventions. And then, of course, we've heard so much about this, the asthma triggers, many of which we can empower our patients and educate them and their families and their environments on how can we control those things. And GERD is another one that popped up that I found quite interesting, because that is one that is, now we have a comorbidity, right? We have a GI issue that we need to maybe also be attending to, on top of possibly the anxiety that comes with asthma. And so kind of the last little piece related to kind of hard, fast kind of things that our BHCs or our therapists can utilize with patients is the exhale technique. Again, a lot of information on here, but really just making sure that there are multiple opportunities to talk with people about their asthma. It's very similar to the asthma plan. It includes education and kind of getting rid of environmental things that may be causing. So we talked about a comorbidity with GERD. Well, tobacco use disorder is also one that we would want to pay attention to. We know that we're going to come at this in a very non-judgmental manner and utilize motivational interviewing, but linking those two, it may seem so obvious to us, but it may not to patients. And particularly if any of us have ever been to the doctor, we get tunnel vision, we get overwhelmed, it stresses us out. And so speaking to what we might think of as commonsensical things to focus on may not readily pop into somebody's mind because of the already existing anxiety or stress that they're experiencing in that moment as well. So linking things together for them, kind of laying out the breadcrumbs for them. And I really love this one, home visits. So not every facility is as lucky to have people who visit our patients in their home that are linked to other departments and have a team-based approach. Whenever possible, working with the patient and getting home visits for anything that we can do to reduce any of those environmental triggers we've heard about, as well as how do we achieve our medical management. And I think for me, a centimeter of change is better than nothing. And sometimes that may be the incremental change that they can manage in that moment. And so I think that it's really important to really talk a little bit about what our ultimate goal is, but what are the small steps we're going to take to get there, and then celebrating those and just totally laying it on how hard they worked and how important this is to them, and that we share in that success with them and that happiness with them. And then, of course, any team members that we can coordinate and link together. And lastly, as we've talked so much about, the environmental policies. So these two are similar, somewhat different. I invite you to kind of look at them a little bit closer. Maybe one would be more appropriate for a certain patient or population, and then the other one may be more appropriate for the other, maybe using them in conjunction. I don't think there's a wrong way per se to use these, but these are definitely wonderful jumping off points for specific intervention strategies and assessment strategies for our BHCs to utilize.
Okay, thank you, Michaela. So I am going to review some of ethics that are related to asthma care. And so I will try to be brief. A lot of what I found, I think, is maybe more interesting potentially for discussion. So as I said, I'll try to go through these fairly quickly. I think most of us are likely familiar, excuse me, with the principles of biomedical ethics article, sort of from Tom Beauchamp and James Childress, that came out in 1985. And while these principles
We've lost you, Robin. We'll give her a second. There's been worse faces to freeze on than this, though. We've all experienced. Okay, she's gone. So let's jump into our discussion. When she returns, we'll pick up on ethics. I don't know really what we want to, if there's anybody who's had something they've been holding on to, I'd like them to ask that during this time. This would be a good time to kind of fill this space until Robin returns. Otherwise, we can ask some questions. Any experiences anyone in this roundtable has had with treating asthma, and whether it's adult or children, and what has that experience been like for you?
I don't know if you all know how to use the reactions tool in Zoom, but on the bottom right of your tab where you can see mute, video, etc., there's a little reactions button and you can hands up or high five or whatnot. So even just by like a wave or show of hands, those of you who have dabbled in trying to treat asthma in your settings. I don't know if that means that nobody knows how to use the hand tool. Hey, Michaela's waving. I can wave. Or that we have asthma novices here, which is interesting to me. I think asthma, like diabetes, like weight management, et cetera, it feels so daunting, especially if you're in an outpatient setting, not a, like a primary care setting. But these are apps, and even honestly, even as a BHC in a primary care setting, I think we tend to stay away from these things. There's so much behavior in chronic disease, and this is absolutely your all space. Don't be afraid of this space.
I think back to also when I was in an outpatient setting, how often I was experiencing individuals with comorbidities and I didn't exactly know what to do with them. I knew they were impacting my care because they were kind of trumping what I needed to do, and I needed to address them in order to get to where I felt like would be beneficial for the patient and where they wanted to go. But I also couldn't communicate with the physicians and in the primary care setting. I didn't know how to kind of link those two. And this is such a great space to learn how to manage chronic illness and be able to address them and not necessarily have to communicate if you're not able to with that primary care physician, although communication is ideal and an embedded clinician is really ideal. And I think this is a good space to do that. So is there anything that we've talked about that feels uncomfortable, since some of you have not had that experience in treating asthma? Does this feel uncomfortable to do in the space that you're in now?
I'll just say that it's just, granted, I'm not asking about it, but it hasn't been freely offered or brought up with me, with the folks that I work with. So it isn't something that I had ever really typically thought about in terms of how I would address that with the patient. So this is really good info.
I will say that yesterday I had a conversation with one of my interns who's also doing some BHC work, and she essentially asked that kind of, Paul. She was like, I get in the room and it just feels so overwhelmed. There's so much to do. And I said, well, on the flip side of that, that also means that we can choose anything and it'll be impactful. And that typically that creates like a snowball effect. And so how do we start that conversation with the patient? I think that utilizing your own strengths and personality is really valuable. I tend to kind of come from a place of humor. And so I said, I may say something like, I love cake and salad kind of makes me sad. So I'm right there with you. So, does that open the door for us to kind of talk a little bit about their diet and weight management? Maybe. But I also think that it's somewhat disarming too. But I think that at the end of the day, giving our patients the opportunity to say, this sucks, and how do we handle, like, again, there's probably 45 other talks we could do about this, but there's a grief associated whenever someone is diagnosed with something because it is a loss of. And so there are multiple facets, but at the very minimum, just talking with our patients about what is the one thing, knowing there's a million things, what is the one thing that we can focus on and work in hopes that it will build onto others.
And to build on that, I was never trained before I got into integrated care to ask my clients about their physical health. We just weren't. But if you think about yourself, when you have any kind of physical health, like, and I mean, like, I have a giant bruise that hurts me, like, it is so top of mind, right? Our physical health impacts our cognitions, our emotions all day long. And so at a minimum, I think it's important that we start to ask that question. You know, how are you doing physically? Are you healthy? Do you have things that, you know, that cause barriers for you to just open the door? And then as those come in, then we can dig in and see, you know, is that well managed? Is that something that is a big source of stress or grief and loss? But just opening that door a little bit, it's fascinating how many things will come in, because that stuff really is so important and prevalent in our day-to-day life.
Kristen, we have a couple questions from Chuck that I think maybe you'd want to respond to.
Sure. I saw the one come in about the best way to hook kids into better self-care. I think that's a great question. And if anybody's ever heard me talk about anything related to care with children, my answer is always the same, but it starts with the parents. It starts with parents having buy-in that that's something important to pursue. It starts with good modeling, and it starts with behavior shaping. So, you know, a good sticker chart used well is like the solution to everything. So, you know, if you're trying to shape a behavior like medication management, and it's new and it's not going well on its own, then put it on reinforcement and build up rewards around it until that behavior is really learned. The other thing I would say, you know, about just medication and chronic illness in general, when kids start to have a lot of treatment, it stinks. Things like diabetes and asthma, where you're having just daily things you have to do. So the degree to which you can make it fun, involve kids in their own care, and give them a sense of agency around that. You know, so just examples with my own child and asthma, you know, we early on, he holds his inhaler, I puff, we have a routine, we work together, we count. When he's sick, we have a coughs go away song. It's, you know, just all these things that you can build up to make it feel fun and developmentally appropriate so they can access and understand what's happening. Robin's back.
Well, if that wasn't excellent timing, I don't know what is. I apologize, everyone. Chelsea, would you like me to go through the last just a few minutes of what I was going to present? And okay. Ethical care includes having a solid connection to your clients and to your colleagues. So I apologize about that, everyone. Chelsea, I'll just jump I know you're going to head to the slides, but I'll just go ahead and sort of jump into what I was saying. So again, I think everyone on this call is fairly familiar with those four healthcare ethical principles that I mentioned. And so in no way am I here to dismiss everything that was just said. I just want to bring up a few pieces for consideration in terms of what we're doing, not just with asthma care, because certainly Kristen, Michaela, Chelsea are all showing and utilizing evidence-based treatment, the CDC, the NIH principles. One of the things that I wanted to mention is simply, can you go to the next slide if you're able? Talking a little bit about autonomy. So with autonomy, one of the things that can happen, and we've already, again, mentioned this to some extent, there's been large qualitative studies done. The particular one I'm referencing now, we do have a reference for it, is sort of patients wanting to live what's called an unconstrained life. So a recent study in the United Kingdom showed that 2 out of 3 individuals with severe asthma are not able to work due to the amount of hospitalizations, due to the severity of symptoms. And so this qualitative study, interviewed 29 people from between 1.5 to 4 hours and really looked at what does it mean to be a person that lives with asthma. How does that help, hinder? Where are you feeling like you can have control, right? Autonomy is about making decisions about our own bodies and about what happens to us in our healthcare adventures, so to speak. So two of the main themes that came up were patients' desires to live an unconstrained life. And so certainly what my colleagues have referenced earlier in terms of knowing how to utilize self-management, knowing when to utilize treatments at home versus to take it to a higher level of care. This kind of education, this kind of self-management can certainly help individuals to feel that they are living, less under strict rules where they have to sort of perform just according to what the physicians say or what their behavioral health care provider says, but to really have that patient-centeredness. So when we talk about patient-centered care, really autonomy is underneath that principle. So we want to make sure that we're working the best we can to help individuals live sort of their best lives, for using a little bit of a cheesy phrase, as well as preserving self-identity. That's another theme that came up very frequently in this qualitative study. Again, people wanting to maintain the activities, the parts of their lives that bring them joy. So learning, how do I still exercise? If physical activity is a trigger for me, how can I work with my healthcare team to make sure that I can still be as much of who I am as possible while still living with this particular disease? And as mentioned, I think Kristen did a good job of mentioning things like blended families, as well as the pediatric part of asthma management is, if autonomy really refers to us being in charge of our own medical decisions, well, how does that change, or what does that mean when we need support if we're an asthma patient or an individual living with asthma? How is the family involved? Who is the support network? And even for children in particular, who is in charge of decisions? Or for individuals that may, I even was reading a little bit about an article before we hopped on about individuals with developmental disorders and maybe having a power of attorney or somebody that's in charge of their medical decisions. So how do we balance that need to be unconstrained, to live our own best life, but also utilize additional support, be that the healthcare team and or our family, our blended family, and how much decision can we as an individual living with asthma have in terms of our care? So, Chelsea, we can move forward. Okay, so beneficence, just a reminder that we want to do the most good for patients. So again, all of these healthcare ethical principles are really so that we provide the best treatment and the highest level of safety in our interventions. So while most of us probably aren't medical doctors, one thing to keep in mind is that as much as we focus on the medical aspect of asthma management, there's a fair amount of evidence that the medical interventions, just a low percentage of them, a fairly low percentage of them actually have the strongly recommend or recommend level of treatment. So several of the options that physicians are working with through no fault of their own really are optional, right? The C and D piece of the level of evidence. So most of what we're talking about today even though there's a lot of support within behavioral health care itself for brief interventions, for self-management, patient education, teamwork, motivational interviewing was mentioned several times, that these things are found to be effective in integrated healthcare teams. A lot of the recommendations specifically for asthma management are actually rooted in specialty mental health care. And so it's not to say throw away everything that you've heard, certainly. It's just something to be aware of, that there are no large studies yet done or found in the literature. So any researchers out there who want to grab onto this, that show that these recommendations have been used in specialty behavioral health care specifically for integrated care of asthma. So I hope that I'm being clear. There's the evidence for these interventions in behavioral health care, and many of them cross over with the advice that we're giving surrounding asthma treatment, but that's mostly from either specialty behavioral health care and or even nursing education. So there have been shorter term interventions with nurses, for instance, that give a 1 hour self-management and educational piece that does show quite an increase in patients' lung function. So I just wanted to bring awareness to this, that we keep in mind what we're using and how we're consuming data. So again, given that many of us may be mental health professionals and or, well, we'll go with that, that many of the medications that have been referenced, especially corticosteroids, et cetera, some individuals can be very sensitive to those medications, and a lot of the presentation can show up as anxiety. So we need to be well versed enough to know what is the difference between a side effect of a medication that causes me to have some tremors and that causes a change in my heart rate versus true anxiety. And the two certainly can be comorbid. A lot of individuals with asthma will have panic, but we want to be really informed about the medications that are being prescribed by the physicians, so that we can do some really close differential diagnosis as to whether we're going to add an additional anxiety diagnosis, or is this a fairly common side effect of the medication regimen. You can move forward, Chelsea. Okay, so I don't think I need to spend much time here. We've certainly covered the social determinants of health, race, income. This slide is quite a bit less informative than what my colleagues have already discussed, but I knew they were going to do that. So we know that the burden of asthma is unequally distributed. I think one of the pieces that's interesting in terms of justice per se and this unequal distribution, it makes me think a little bit about even COVID vaccinations right now, where we're starting to see in the United States that we have more supply than demand, disappointingly, versus other areas, other countries with less wealth who have a higher demand than supply. So again, it's something to be aware of in terms of, you know, what is our responsibility in working with healthcare systems, in working with the broader social justice systems to make sure that we are moving forward in terms of more equal distribution and a clear understanding of how these social determinants of health may be mitigated, may be assisted in some ways. And finally, non-maleficence. So this one really is one of the more common healthcare principles, I think, that we think of, which is simply do no harm, right? So again, it is not to say that everything we're talking about today just flies out the window. These are just reminders that even with the best of medicine, even with our best knowledge, staying current with the evidence, we cannot always, it's frankly impossible to predict with precision who will respond to what treatments in what way. We like to think, especially with things like medication, that there's a fairly consistent response, and that's not entirely true. People are so individualized and live in such unique circumstances. Every person is a world unto themselves. And so even with the best evidence that we have, we need to be aware that not everybody is going to respond in the same way. So if we're talking about treating an individual with asthma who has mild symptoms and has gained a lot of control, and symptoms are pretty minimal, some providers will move into the idea of weaning the controller medications, the more immediate acute medications. But we don't know for certain how individuals will respond to that. So it's just something to be aware of, that when we make changes to individuals' plans, that we need to treat it as an individualized decision and follow up closely with whether that intervention was appropriate for that individual. And then finally, again, as mental health professionals, we really want to be aware always, but specifically when we're doing self-management plans and interdisciplinary work, about the limitations of how we talk about medication with our patients. So as always, it's good for us to know the basics of what the medications do, but when we're starting a personal action plan, it's really best to have the physician involved in the steps. Like Michaela had mentioned, there are certain steps that you want to take to make a decision about, do I need to head to the emergency room? So we would want to have the physicians involved in really describing that to the patient. And then we come on board to help with the self-management, the motivational interviewing, etc. So the last thing that I'll say, and I do want to again point out that there is a lot of evidence for the brief interactions and interventions that we're talking about in terms of education, self-management, motivational interviewing. We just need a little bit more research on how that plays out in an integrated healthcare setting. And so we don't have to jump right into this question, but one of the things that really caught my eye when I was thinking about this presentation was the idea of autonomy. And with, there's a very specific definition for that in the medical literature, where we're allowed to support and advise, but not persuade. And so when I think about motivational interviewing, I'm directly trying to persuade a patient to do something that's good for themselves. So that was a really kind of a little question that came up in my mind. Is motivational interviewing advising and supporting, or are we moving into coercing, or even if it is our belief that it's best for the client or the patient? So I'll give myself a break and hopefully stay on for this period of time. And I'm so sorry for the interruption.
We could talk about this. So there's so many things that we would like to answer and have a discussion about. Unfortunately, we're out of time. So I do want to say that if you're a MOPA member, you will get an evaluation, complete that, and you'll get your CE. If you're not, you need to email support@mopaonline.org. Yes. And Emily will send you an evaluation and you can get your CE through her. Thank you guys so much. We do this every first Thursday of every month. We hope to see you soon. Have a good afternoon.
Thank you, everyone.